Am I audible, sir?
Yeah. Good evening, all. So welcome to the 16th postgraduate training program initiated by Ampok. So today we'll be discussing a case of lymphoma. Lymphoma, we all know as a postgraduates, DM medical oncology students, know that's definitely it is going to be a long case. I mean, it will be there, that's for sure. So today we have none other than Dr. Hari Menon sir, who is actually a veteran, a great teacher, a great speaker. So he's been into hematological malignancies for a long time. So it's the best opportunity to learn from Hari sir. And along with that, we have Dr. Nikhil also is there. So without wasting much time, I request Dr. Hari sir and Nikhil to take over the proceedings. Thank you.
Thank you. Thank you, Bobbin, and hello, Dr. Nikhil. So can we go ahead with the presentation, and then we can take it forward.
Please start.
Yeah. Pardon?
Am I audible, sir?
Yes, you're audible. Could we just go onto the full screen? Yeah, slideshow. Yeah. Yes.
Good evening, sir. My patient is Mr. X, a 53-year-old male, hails from Kottayam, and he's a resident of Oman, and he's a sales executive by occupation. His presenting complaints were a swelling in the left side of the neck noticed for the past 2 weeks, and associated abdominal discomfort noted since last 1 week. Coming to the history of presenting illness, he was apparently normal till 2 weeks back when he noticed a swelling in the lower part of his left side of the neck, which was sudden in onset and initially about the size of a pea and increased in size to attain the present size of a small gooseberry. It was not associated with any pain, ulceration, or discharge. No history of associated loss of appetite or loss of weight. No history of fever or drenching night sweats. No history of any bleeding spots on the skin, gum bleeds, or any other bleeding manifestation. No history of associated cough, breathing difficulty, or chest discomfort. And he had associated abdominal discomfort, which was more towards the left side of the abdomen, noticed for the past 1 week, which was associated with intermittent dragging pain. And there was no associated history of abdominal distension, vomiting, or altered bowel habits. No history of jaundice, no history of reduced urine output or bone pains, no history of associated headache. And there was no other associated significant systemic complaints. Coming to the past history, no history of similar complaints in the past. He's a known diabetic on oral hypoglycemic agent for the past 8 years. No history of hypertension, cardiac disease, or TB or other comorbidities. No history of any previous hospitalization or transfusions. No history of malignancy in the past. Personal history: he takes a mixed diet. Bowel and bladder habits are normal. No history of smoking, alcoholism, or any kind of substance abuse. Sleep and appetite were normal, and no known drug allergies. Coming to the treatment history, no history of previous hospitalization or any significant treatment. He's married for the past 26 years with 2 children. No history of any sexual promiscuity. And coming to family history, no history of any malignancy among his family members.
Okay.
Summarize my history. He's a 53-year-old male who's a diabetic, presenting with left-sided neck swelling for the past 2 weeks, associated with left-sided abdominal pain, with no other significant personal family or a treatment history. So,
okay.
Consider.
So you have a 53-year-old patient. From whatever the history that has come up, there might be some sort of an interpretation that will be formed in your mind. What do you think? How you should proceed and what will happen in your clinical findings from here on, what you can understand from the history over here from this patient. There are a few key features that are reflected over here. So certain patterns that are reflected over here. So how would you formulate what comes to your mind over here?
So I assume considering the location and nature of the swelling, I assume it to be the next swelling to be a lymph nodes, and maybe the abdominal discomfort related to some organomegaly. Considering the left-sided thing, maybe splenomegaly.
So in your history, did you try to get a little bit more about that abdominal discomfort? What is the nature of that abdominal discomfort in your history? Any pattern to it? Is it continuous? What kind of a discomfort is it? Is it related to some sort of I mean, how does it transpire during the course of the day? And has the intensity increased over the last few years, a few months or few days, whatever? So have you elicited that kind of a history for us?
Yes, sir. He reports it to be a persistent discomfort and associated with a dragging pain, which is more at night.
Okay. And this is on the right side, on the left side.
Left side of the abdomen.
So, okay. So what is that? You have that there is a certain, specifically he says on the left side, isn't it? And you have which you assume that is a lymph node swelling, and because it is, suppose this lymph node was higher up on the neck side, what would that change your interpretation of things? You said this is on the lower side of the neck, isn't it?
Yes, sir. Lower part of the neck.
Yeah. So how would you interpret the lymph node depending upon the location of the lymph node on the neck? Yeah. So it's just trying to formulate something, because everything about history is to sort of get it down and percolate down to what you need to do subsequently, and try to predefine what you will find in your investigations, in your clinical evaluation, isn't it? So that's what I'm trying to encourage you people to do. Yeah. So can you formulate something out of this? So here is a patient you have having no B symptoms, a relatively short history, and a concomitant presence of a lymph node in the neck with a concomitant symptom of some abdominal discomfort, which is specifically said to the left side.
Vishnu sir wants you to, with this history, to formulate and try to put it to a single probable diagnosis, or and also, try to put into a single probable syndrome bar diagnosis. That is what sir is asking you.
I'm thinking of a cervical lymphadenopathy with a splenomegaly, probably, sir.
So that's something that, because he's specifically saying some dragging pain on the left side of the neck and is not associated and is not specific. There is a lymph node. So you try to correlate something like that, isn't it? You have a middle-aged person with a cervical lymph node, and he's got something. So something that formulates is, okay, this patient might be having a splenomegaly and he has got a lymph node. And then you start thinking, how many, if you are thinking in terms of a lymphoma over here, which is the point of discussion, how many lymphomas will manifest like this? So you start thinking, isn't it? What is going to be your real interpretation? I mean, it is just trying to formulate what you might think. So it's always exciting to really try to formulate what you're going to find. It might be wrong, but you at least try to narrow down. So you get what I'm trying to say. So what you said is correct. You have a lymph node. You have, probably it's a spleen, and he's not having any B symptoms, and we are sort of progressing. Okay, let's go ahead with the remaining history. If you have anything else, you have already summarized. So can we go ahead with the clinical evaluation then?
Yes, sir. Coming to the general examination, he was conscious oriented. He was moderately built and nourished. He was his performance status was 0. Height was 175 centimeters. Weight of 76 kilograms. BMI of 24.8 and BSA of 1.9. There was no pallor icterus or pedal edema noted. No petechiae or purpura noted. There was generalized lymphadenopathy, to which I will come later. No facial puffiness, engorged veins over the chest. Skin and thyroid were normal. Coming to vitals.
Talking in terms of what about the oral cavity? Have you examined the oral cavity?
Yes,
and if speaking in terms of a lymph node around in the neck region,
yes,
we have to look at the oral cavity.
Mentioned along, yes, I have mentioned along with the systemic examination, GI. Oral cavity was normal, so tonsils were normal, Walde's ring were normal.
Okay.
So,
And
more than saying normal in such a case, Vishnu, I
So,
think you can
yes.
bring out the focus areas of what you examine in the oral cavity. That may have much more of a impact.
Correct.
For example, the Walde's ring, etc. So even though it's normal, the examiner knows that you have focused on these areas, particularly in your
Yeah.
examination.
Exactly. So here at your level, you're looking at a focus. You're obviously you are dealing with some sort of a malignancy at your level because you are in that field, and so you can really be specific about what you're looking for, isn't it? Yeah. Rather than giving multiple negative histories.
okay.
Yeah. So in this situation, maybe the evaluation of the oral cavity should come in the general examination. You don't have to go hard and fast into. That's what happened because you're looking at a lymph node over here, and you want to straight away look in the general examination of oral cavity, isn't it? Yeah.
Yes.
Yeah. Yeah. So you say the oral cavity is normal. You didn't find anything abnormal of the oral cavity.
So tonsils were not enlarged, Walde's ring was normal.
Yeah. No,
Vitals were
because you
normal.
have a lymph node in the neck. Is there anything else that you might find in the oral cavity, like a non-healing ulcer or something like that? You need to. So those are negative. So it just gives an idea that you have been thinking about certain things. Yeah. So that's what you need to interpret at your level when you are. Okay. Yeah.
One more, this thing, Vishnu, what do you mean by generalized lymphadenopathy in your general examination?
So I'm coming to the lymph node examination in detail, sir.
No, but what do you mean by generalized lymphadenopathy? So that is something that strikes out. Generally, a lot of the lymph node examination, there is no right way about it. Each person, I do agree, you can say that I'm going to examine the lymph nodes separately or in now as a part of a local examination. But generally, since you've already used the word generalized lymphadenopathy, anybody can just ask you just to throw you off your rhythm. You're focusing on what is it? What do you mean by a generalized lymphadenopathy?
Sir, presence of two or more non-contiguous areas of lymph node enlargement is defined as generalized lymphadenopathy.
Okay. So I think such terms like generalized lymphadenopathy, etc., in a medical oncology examination can be avoided because it causes too much ambiguity. Unless you really have a patient who is having involvement of more than two non-contiguous lymph node groups. Okay.
Okay, sir.
Go ahead with. Sir, anything to add?
No,
You said
I
that-
would say that it would be more right to say if you're seeing there are multiple lymph nodes palpable or something like that, instead of saying generalized, because that then, yeah, I agree with you. Yeah, so you can say besides the lymph node that is evident, which has been identified as lymph node, there are other multiple lymph nodes palpable, and then you can come to the main examination later on. Yes, yeah.
So, on inspection, there were two distinct swellings in the left side of the neck, in the lower third of the neck. One was around 2 into 1 centimeters, and one was around 2 to 2 centimeters. There was no retinous discharge or sinus over the swellings, and the same was confirmed by palpation. And upon palpation, there was a right axillary node, 2 into 1 centimeters, the central group, and bilateral inguinal lymph nodes were palpable. There were 3 discrete swellings on the right side, largest of which was 2 into 2 centimeters. And on the left side, there were 2 swellings, largest which was 2 into 2 centimeters. These nodes were mobile, non-matted, soft in consistency, non-tender, and there was no local rise of temperature. The skin over the lymph nodes were normal, and there was no popliteal, epitrochlear, or occipital lymph nodes palpable.
So when you talk about the bilateral lymph nodes, it would be more professional to say the vertical group, the horizontal group, the deep inguinal group. You can be more specific. So that becomes a lot more to the person whom you're presenting to, or interpretation. It becomes easier when you document it that way. Yeah.
Lingual lymph nodes were palpable in the horizontal group, sir.
Yeah. Okay.
The systemic examination, coming to the GIT, oral cavity was normal, no tonsils was normal, no Walden's ring was normal, no ulcers or swellings within the oral cavity. Inspection, the abdomen was slightly distended, umbilicus was flushed with, and on quadrants were moving equally with respiration, no distant veins, scars or sinuses. On palpation, liver was palpable 4 finger breadths below the right costal margin. It was non-tender, smooth surface, and border was smooth. Spleen was not palpable. Percussion, no shifting dullness or fluid rate. Auscultation, no hepatic brewing. External genetic tests were normal. And other systems were within normal limits. To summarize the case, 53-year-old male, diabetic, presenting with left leg neck swelling for 2 weeks, associated with abdominal pain for 1 week, and on examination having generalized lymphadenopathy with left cervical, right axillary, and bilateral inguinal lymph nodes, and hepatomegaly, with no other systemic significant examination findings.
Okay.
Differentials would be either lymphoma or an acute leukemia.
So why do you say, why do you put a diagnosis of an acute leukemia over here? Does he have any of the symptoms that are suggesting of an acute leukemia over here? And do you think that a patient with an acute leukemia with lymph nodes which are so far distributed, I will not say it's a uniform distribution of lymph node, and having an isolated hepatomegaly, not having a splenomegaly, would you put an acute leukemia over here? And I just was wondering why you would think about an acute leukemia over here.
No, I would consider a lymphoma, possibility of a lymphoma first, sir. And maybe down the list, he's relatively well preserved for.
When you say down the list, that means there are maybe more than 2-3 items. Do you want to one by one say what else might be in your mind? Fair enough. You're thinking of a lymphoproliferative disorder, a lymphoma probably.
Yes.
Do you have any other thing, maybe some other characterizations? Of course, the final characterization comes after we get down the road, but then do you have anything else? What possibly could it be? What type? What subtype? Any
Probably
clues or anything? See, all these are suppositions at this point. We have a few points which are in favor of something. You have a few points against. For example, you told about acute leukemia.
Non-Hodgkin's lymphoma, an aggressive.
Why do you say it's an aggressive? Why do you say it's an aggressive over here? Do you think it's that? Would you say that's really an aggressive kind of a lymphoma? Here is a well-preserved. He doesn't have any B symptoms. He is having relatively small nodes. He doesn't have he's got some vague abdomen. You don't have any abdominal findings. And there, you can say moderate, not even a moderate, it's mild lymphadenopathy, isn't it? So why would you like to narrow down something over here? I mean, just try to say, would you put a high-grade lymphoma as first over here, or would you consider it as something like a low-grade lymphoma? Or would you consider something like some of the other chronic lymphoproliferative disorders?
Would your hepatomegaly and all that add a value to something else? Would you consider something else in favor of a low grade or an indolent lymphoma rather than a high grade, or the other way around? Organomegalies are more common in what? You're thinking of a high grade lymphoma in view of
Yes,
the
sir.
short history, correct? But generally, high grade lymphoma, almost majority of them would be associated with some constitutional or systemic symptoms, right?
So,
Whereas this is behaving like this guy one day, actually, it might have been there earlier. You know how we are when it comes to self examination and care. He might have just noticed it currently in his, in the recent times. And since then, his attention has gone towards that and he feels it is growing in nature. Are there lymphomas which do also have some waxing and waning also? Do we see some type of lymphoma, SLL? Do we have waxing and waning of the sizes and distribution?
yes.
I mean, I don't know whether I missed that history. That's an important point, actually. Yeah, yeah.
Vishnu, I think you
So,
can, there is no, you are right. All of us are going to present this patient as a lymphoproliferative disorder. You, at this point of your discussion in DM, DRNB examination, they're going to ask you about what do you think is the possible. They're not going to just ask you, okay, lymphoma is not enough for us. At this point, you think of a Hodgkin's. What are the points against Hodgkin's? Are you thinking about non-Hodgkin lymphoma, indolent versus high grade? You need to, from what you are told, you need to pick up the points which are in favor. Some of these points will be in favor of one thing, some of the points will be against that. At the same time, you need to have your backup DD. You're assuming this patient has not been worked up. You're getting this patient without a further evaluation done. So you need to also assess it. There was a reason, sir, asked you in a patient with neck swelling to do the oral examinations. Can this be some form of a, the neck node can be metastasis, right?
yes.
But then what is against metastasis of unknown origin or metastasis of unknown primary? You generally don't get such a non-contiguous distribution of
Yes.
lymphadenopathy.
Yes, sir.
So the important thing
Considering
for you to argue out your case as to why this should be, this is the case. That's the important. I mean, you can. That's the way that, again, as I again said in the first, you have to funnel down your diagnosis to some extent so that we move ahead from there.
So considering the non-contiguous nature of the lymphadenopathy, I would consider a non-Hodgkin's lymphoma. And
Okay, you say it's a non-Hodgkin's lymphoma, but so now then, you need to narrow down a little bit more as to if you think it's a non-Hodgkin's lymphoma, then 1, 2, 3, what are your possibilities? Yeah.
probably a DLBCL, considering the short history and the most.
Anything
You
else?
want to put diffuse large B cell as a primary, first choice, but you wouldn't want to put a low-grade lymphoma as the first choice over here. Fair enough. You can see, but again, then you have to argue why you want to put DLBCL as the first, or a high-grade lymphoma as the first choice.
Mainly because of considering the short history of symptoms.
It is quite possible that he has just picked it up recently and then noticed it. Yeah. But yes, you did mention that it has increased over the 4 weeks from a pea size, as you said, to a little bit more bigger size. Okay, fine. That's all right. But look at the pace of the disease as such a high-grade lymphoma, you would also notice that you would also have other constitutional symptoms coming in, yeah, which is something which is unusual. I mean, you cannot be dogmatic and say that that is a thing, but usually when you are having a 4-week history, then you're thinking it's a high-grade lymphoma, then you would have some associated constitutional symptoms, especially when you say he's got disease both supra and infradiaphragmatic, assuming that all those inguinal lymph nodes are positive. And he has abdominal symptoms, which means that you might have abdominal lymph nodes also. We don't know. Yeah. 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 So go ahead, please. Yeah.
Coming to his investigations.
So starting from here, okay, you have this thing. What are the first preliminary investigations, I mean, relevant, that you want to really look at? So everything about doing an investigation, okay, you have the associated investigations that everybody will run. But what are the specific investigations that you will run without question for us to get started on planning what your other investigation should be subsequently? Yeah. So there has to be a sequence to that also, isn't it? So how would you go about that?
So as diagnostic investigations, I would like to get a complete blood count. And I would like to get a cervical lymph node biopsy done, an excision biopsy done.
So, would you want to? So, if you're looking at, for example, this patient is having mild to moderate lymph nodes. He has some abdominal symptoms. He is not having any constitutional symptoms. He is 53 years old. What would you look in the peripheral smear specifically over here? What is it that you're going to emphasize on looking at the peripheral smear? Have we lost him or something? Yes, sorry.
No.
Yeah. What would you like to look at the peripheral smear for? Yeah.
Yeah, atypical lymphocytes. So your voice is cut off.
So you are looking for the possibility of a chronic lymphoproliferative disorder like a CLL or something over here. So that's what you want to look at. Sometimes you can get in a follicular lymphoma also, you can get certain atypical cells circulating in the peripheral blood. So these are the things that one has to pay attention to. And when you look at that itself, you seem to be able to sort of, again, the bottom line, you're able to funnel down some of the diagnosis very quickly, isn't it?
So,
please go ahead. So what did the peripheral smear show? Yeah, yeah.
Sir, complete blood count was normal with a hemoglobin of 14.1, total count of 6,400 with 62% neutrophils and 26% lymphocytes, platelet count of 3.09 lakhs. Peripheral smear was normal. ESR was 14, LDH was 155, and renal function and liver function tests were within normal limits. And TLS markers were within normal limits. Potassium was 3.9, uric acid was 5.5, calcium was 10.2. When phosphate was 3.2. Viral markers were normal, and coagulation parameters also were normal. We got a HCT done, which showed bilateral, bilateral cervical
Why would you go for a PET CT? Why? I mean, if it is it the norm to go ahead with a PET CT just straight away rather than look at what you rather than trying to establish the diagnosis and then looking at it? Yeah. So what will be your next test that you need to do?
Cervical lymph node biopsy.
Yeah. So why would you go ahead and do a PET CT? Is there if you want to do a PET CT, what are the criteria that you would look for to do an early PET CT before a lymph node biopsy? What would trigger you to do a PET scan before doing a lymph node biopsy?
If you are suspecting a metastatic lymph node deposit rather than
No, but then you can you first need to establish the diagnosis, isn't it? Because if you are having a lymphoma, you're likely to have any stage of the disease that
or
can.
if the initial the peripheral lymph nodes are not accessible, I mean, for a biopsy.
Okay. So what are you more concerned about when you are dealing with a clinical diagnosis of a low-grade lymphoma and you want to do a PET scan upfront for such patients before doing a lymph node biopsy? So what would trigger you? Again, I come back to the question. What would trigger you to do a PET scan earlier than a lymph node biopsy in a patient where you suspect a low-grade lymphoma based on some of the parameters that have already been done? So would you want to pick and choose the lymph node that you want to biopsy?
So,
yeah.
Where if the yield with the peripheral lymph node biopsy is
no, how will a PET scan help over there? No,
suppose
suppose you are looking at you're seeing that this is a low, you say that, okay, I feel that this is a low-grade lymphoma, but the LDH levels for some reason has come up high. And then you want to do a PET scan over here and you decide that you want to do a PET scan, but then you have to tell us why you want to do that PET scan upfront over here and what is the rationale behind that.
Clue has been given to you already. So just the examiner has already given the answer and the clue, Vishnu. So the LDH, this thing, just think about it, LDH level, and you're almost sure it's a low-grade lymphoma. I'm also assuming that all the SUVs have uptake. Why would you do the PET scan before going ahead with the biopsy? Beyond that, you just have to add in one word. Why? Or on what would you select?
To biopsy the node with the maximum uptake and most representative node.
And why would you do that? Why do you target that particular node? I'm sure in this case, if I take the axillary node or in the cervical node, let's say it had a SUO 6, whereas maybe probably the
not to miss the high grade component.
18. Yeah. Good.
Yeah.
You're there.
Yeah. So that's right. So you must always look at wanting to identify if there is a high-grade component to any low-grade lymphoma, because in that case, you would rather treat it as a high-grade lymphoma than with a low-grade lymphoma kind of a protocol. That's the only reason where we do. Otherwise, it is always, if you feel that it's a straightforward case and you think that it's always better to go ahead and do a lymph node biopsy first before you plan for a PET scan. Unless you have the situations which we have discussed it earlier.
So we actually did the biopsy first. I mean,
so then you should. So that's precisely the reason. I mean, that's okay. I mean, this is just a discussion and how you need to approach a patient with lymphoma and how your thought process should be. And you should always have a rationale behind ordering an investigation. That's all. Yeah, so go ahead. So what was the lymph node biopsy that was showing? Yes, okay.
So it was morphologically, it was showing intermediate to small sized abnormal lymph node cells with scan pale cytoplasm and round nuclei with angulations and indentations with dispersed chromatin and micronuclei. And IHC wise, it was CD3 and CD5 were positive, and B cell markers were negative. CD4 was weak positive and CD8 was strong positive. So indicating a T cell lymphoma. It was reported as PTCL.
Okay. So what is missing here that one should have actually looked at? What are the markers that are what you would like to identify in a PTCL before saying that it is a PTCL NOS?
So we should first look for CD20 and CD3 and CD5.
That's already been done over here. It says it is negative, isn't it? So
T-cell clonal rearrangement.
no. What are the other markers in a T-cell lymphoma? Okay, we know that it is a T-cell lymphoma. Okay, the T-cell markers are positive, and there is no doubt that this is probably a T-cell lineage. And in a T-cell lineage, what would you like to further classify over here? What are the other other kind of T-cell lymphomas that we know about?
ALCL.
Yeah, so if you want, so you need to, when we are looking at, always see whether there is an ALK positivity or not, isn't it? Even if it means that the thing. So before calling it a PTCL NOS, you probably want to look at the ALK status also, isn't it? Yeah. Yeah. Okay. And what about the CD30?
CD30 was negative, sir. So ALK.
It was not mentioned over here, the CD30. So that's why I asked.
CD30.
Oh, sorry. Okay, I missed it. Okay, CD30 is negative. Okay, all right. Now, suppose CD30 was positive over here, would it change the diagnosis? Would it change it?
No, sir. No.
So what's the CD30 positivity in PTCLs? You should have a range, isn't it? Yeah. Okay, go ahead. Go ahead. Yeah, go ahead.
No.
Why is it important to know what the CD30 status is in PTCLs?
First line brentuximab based.
Okay, and how is it different with the PTCL, I mean CD30 positivity in anaplastic large cell lymphomas vis-a-vis Hodgkin's disease, vis-a-vis a PTCL?
I didn't get you, sir.
No, how is the pattern of expression in CD30 in Hodgkin's versus ALCL versus a PTCL?
ALCL, almost virtually all cases are CD30 positive, sir.
Yeah, and what happens in PTCLs?
PTCLs.
Is it important for us to know that? Yeah.
Yes.
Over here, of course, is reported as negative. Yeah. Okay, fine. But yeah. So it is in PTCLs, not all the cells are positive for CD30. It's a patchy CD30 positivity, but still, so there are several other cells which are CD30 negative also in these patients. So it's not like the uniform CD30 positivity you would see in ALCLs or sometimes for that matter, even in Hodgkin's lymphoma. Yeah. Okay, so go ahead. Yeah. So you said the PET scan was done over here.
Yes, sir.
Yeah, and so what did the PET scan show? Okay, what did the PET scan show over here?
PET scan showed bilateral cervical lymph nodes, sir. subcentimetric right and left-sided cervical lymph nodes and left supraclavicular lymph nodes, subcentimetric again, and along with the right axillary lymph node and mediastinal nodes and lateral inguinal nodes.
He didn't have anything in the retroperitoneum. He had retroperitoneal lymph nodes.
Retroperitoneal nodes are also there, probably accounting for his abdominal symptom.
Okay. What is the other type of PTCL that you would like to exclude over here through the immunohistochemistry? AITL. So what will be the pattern in AITLs? What will be the, I mean, you must understand when you interpret AITLs, what will be the background that you see in AITLs? You must know a little bit of pathology also, remember.
Yes, morphologically, they have prominent high endothelial venules.
Yes.
And scattered immunoblasts.
Okay. Okay. And what about the markers?
And ATL will be CD10 positive, BCL6 positive, and PD1 positive. So.
Okay.
EBER will be positive.
Not necessarily. Okay. Anyway, we don't do generally EBER for when we think about DITL, but there are certain other markers. Yeah, you may want to go and read that up, but it's important nowadays because it is important to distinguish AITLs also when we look at PTCLs. But eventually, PTCL NOS seems to be the most largest spectrum of the T-cell lymphomas that we come across. Okay, so from the symptomatology, what would negate the possibility of an AITL over here?
Skin.
So how do patients with AITL usually present? I mean, what are the symptomatology with which AITLs usually present?
Usually, apart from prominent B symptoms, and they'll have skin lesions. So, voice is cut off.
Sorry. Yeah, I had to. There was some phone call which came in between. That's why I stopped. Yeah. So what are the constitutional? I mean, they come with profound constitutional symptoms, isn't it? And they have a much more extensive kind of a disease, and they usually have bone marrow involvement. Their B symptoms are very profound. High fever, like in anaplastic large cell lymphoma, they also present with high-grade fever. I mean, they present with short history, severe constitutional symptoms, and more of a stage 3, stage 4 kind of a disease. Even PTCLs, yes, I agree, but they are more indolent than an angioimmunoblastic T-cell lymphoma. Yeah. Okay, go ahead. Can we put it back into the slideshow mode? Yeah.
What is now that you have the biopsy, you have the staging workup, what is the working diagnosis right now for this patient? And what would you do next in your OPD?
So working diagnosis, PTCL, considering the cervical lymph node biopsy and IHC report. And it's considering the distribution, it's a stage 3 PTCL.
So how would you counsel the patient over here? How would you counsel the patient as to what his disease is? What are the expectations? What is the how do we need to approach, and how do we know to go up, and what are the expectations over here with the current treatment paradigm?
This is the exact scenario what you face in your OPD once these reports come. You'll have to talk to them. So that is how would you talk to them about your next set of plans, the management, prognosis, right?
So, correct. Considering the present scenario,
How would you like to prognosticate? How would you like to offer your therapies? And whether they are fit for those said therapies. That would be the way your initial counseling, once you get the staging and the diagnostic workup done, is that. Then you have to, yeah.
considering his fitness and age and CD30 positivity, he would be fit for brentuximab based chemotherapy.
But you said here CD30 is negative, isn't it? Yeah.
Yes, yes. CD30 is negative. If CD30 is positive, then CHBVP can
Now
be
we are
tried.
talking about this patient.
We're
See,
talking-
unless
Sir,
we give you a scenario,
if it is
you talk about the patient in front
Sir,
of you.
negative.
Unless sir gives you a scenario, the examiner gives you a scenario, just
Yes, sir.
we talk about this patient right now.
In
He's a stage 3
stage 3
PTCL,
PTCL,
NOS, CD30
lower.
negative, very clear. Let us
No,
assume for discussion sake, ALK negative also. He has only small cells, ALK negative.
IPI is low, so low risk. So he can be treated with CHOP and if followed by consolidation transplant in first remission.
Is there something like a low risk kind of a PTCL? Yeah. Is there something like a low risk CPTCL? So you said
Low IPI is
low IPI. Okay. So he has a low IPI. That doesn't hold so good for peripheral T-cell lymphomas, really. But anyways, how are you going to counsel the patient? Yeah. What is it that this patient, he has comorbidities. He has diabetes, and we are a bit concerned about it in terms of the diabetes with peripheral T-cell lymphomas. And what are the merits of treating him with standard chemotherapy, with the standard protocol of CHOP versus adding etoposide to the regimen, versus using an alternate protocol? What are your expectations out of implementing such kinds of therapy? What are you trying to achieve for this patient through your treatment? Would you always want to use an anthracycline-based regimens in peripheral T-cell lymphomas is a question. And if you have a choice, what are the considerations for choosing your treatment?
age. Yes.
So he's young. He's
Yes,
53 years. Yeah. Yeah.
And comorbidities wise, he's having well-controlled diabetes. No other.
So how much has anthracycline-based regimen contributed to the treatment of peripheral T-cell lymphomas? Is it a must to use anthracyclines always? Or can you sometimes avoid it also? It's a question. And given a choice, which is a drug which is more important in when we treat peripheral T-cell lymphomas? So which is the standard protocol that has been used for treating peripheral T-cell lymphomas?
CHOP is
CHOP, you mean to say CHOEP, isn't it? Yeah. So, yeah. What is the current data for CHOEP regimen in terms of responses and median progression-free survivals in these patients?
CHOP is found to have better median PFS than CHOP with a similar OS in younger patients less than 60 years.
Is it more in terms of the response? Is it more in terms of the responses that you achieve, or is it more in terms of the PFS that you achieve in these patients? So what are your objectives over here for this patient in terms of he's young, he has a stage 3 disease, he has non-bulky disease, and he's pretty well preserved.
So
Yeah. So you just give your sequence. It doesn't matter. Just tell me how would you counsel this patient and how you want to treat this patient. That's all. So would doing a transplant be a priority for this patient? And if you think the transplant is a priority, why would you make that suggestion over here for the patient? And where has transplant helped in peripheral T-cell lymphomas? Has it uniformly helped in patients with peripheral T-cell lymphomas? And in what way has it helped?
Transplantation.
You need to make, the patient is in front of you. You need to make a recommendation and you need to chart out the way that you need to go ahead.
Transplantation in first remission improves both PFS and OS in
Is there an
PTCL.
overall survival benefit, really? Yeah. In transplant eligible patients, especially in PTCLs. And where has there been a benefit for patients for doing transplants? Is achieving a remission important?
Yes, sir, in first remission.
In first remission, you want to do a transplant as well. So,
Yes,
so again, I'm just coming back. At the risk of repeating, you're not committing to how you want to go ahead with the treatment for this patient. This chart out how you want to go ahead with the treatment for this patient. 1, 2, 3. Yeah. How many cycles of chemotherapy and how
six
many
cycles.
you want to
Six
give?
cycles. 6 cycles of CHOPI, and if in remission, followed by consolidation transplant.
Okay. Okay. Yeah. All right. Dr. Nikhil, so do you like to?
I mean, we are assuming this is a T-cell lymphoma, and one other thing in a maybe a straightforward case like this is once you're done, when you're doing the counseling, when sir says counseling part, it is like management. So now that you're done your staging and diagnosis, you should also say the ancillary workup, fitness for chemotherapy. All know this person who is a diabetic, poorly controlled diabetic, you may have some cardiac issues. So definitely that
That's why
question
precisely I asked whether we.
anthracycline.
That's precisely that I wanted to insist that
I
it's
understood that,
mandatory.
but,
It's not
when you're
mandatory.
counseling, this is what you all need to add on. Is it mandatory for anthracycline or can we eliminate anthracycline? We take those decisions based on that. So your workup for fitness should be mentioned. You can commit to a treatment. You, as even NCCN is giving a lot of regime, you can select. There are also variations of CHOEP and as you mentioned, CHOPI. CHOPI is a lower dose of etoposide, mostly given oral, right? Day 2 and day 3. It is fair enough for you to commit, but commit to one of them and keep the answers coming. You're not completely wrong. It is just that we're looking for additional justification when you tell an answer. Try to keep, telling the answers. You have the ideas in your mind. Don't feel that you're not having the ideas. You are correct in that particular aspect. And when you're counseling a patient for the first time, you have to give them a pathway. Transplant is a possibly provided. And there is, I think, sir will be the expert in that, but there's a lot of conflicting data. But generally, in certain patients who achieve CR, a CR1 in a T-cell lymphoma, there is a benefit of autologous consolidation autologous.
In fact, it is probably the only lymphoma where you would consider frontline autologous transplant rather than at the time of relapse. Yeah. Yeah. It is controversial, but in a good fit patient who has achieved CR with primary treatment, transplant would be a good option to consolidate in terms of improving the progression-free survival in these patients. Yeah.
The patient has achieved CR post 6 cycles. You have offered him transplant. What is the protocol, institutional protocol there? You are at MVR, you have access to all the facilities. Patient has achieved. So generally, how? Okay, I'm framing it wrong. How would you follow up? When do you assess the patient? What is your protocol for a response assessment, and how do you proceed ahead? You started the CHOIP regimen.
So, would reassess after 3 cycles, sir. And
Yes, after 3 cycles. Okay. Yes, after 3 cycles, response is the. Does the 5-point PET
You-
play a role in this disease?
Or do you expect a
Yes.
complete response after 3 cycles over here? Unlike like a B-cell lymphoma, do you expect a complete response after 3 cycles or 4 cycles, these patients? You can, I mean, but you may not get as good a response as you would for a B-cell lymphoma. So it doesn't become so important for us to. So suppose you have a patient where you can actually physically evaluate the responses to a primary treatment. It is not mandatory for us to just do a PET scan just to see that it has become CR or something. So you would plan, and if you have something like a transplant plan for the patient, you may want to do a PET scan maybe after 4 cycles so that you can look at consolidating with a transplant subsequently. Yeah. So that would be one of the approaches, because like in all lymphomas, giving more is not essentially better, but giving appropriate dosing and giving a treatment, a planned treatment will translate into better outcomes than having a sort of a sort of a stuttering kind of a treatment that you would give the patient. Yeah. So the patient has been what has been planned for this patient just now? I mean, has the patient completed the treatment, and what are the responses for the patient?
No, sir. We are yet to start treatment for this
Oh,
patient.
you're yet to start the treatment for the patient. No, suppose this patient comes. I mean, you decide, okay, he goes in for a transplant and he's doing well. And suppose this patient has a relapse. What are the options that you can give the patient at the time of relapse? Because you would expect this patient to relapse even after the standard treatment. That is actually the natural history of the disease. More times than not, they would relapse, isn't it? Yeah. So what are the options that you can give the patient at the time of relapse? Or have they worked? Do you have some of the newer drugs that have looked at some of the studies which have looked at? What are the options that you can give the patient?
In relapse setting,
What are the drugs that are used in relapse setting for peripheral T-cell lymphomas? Let's come down to that. I mean, yeah.
drugs under investigation for relapsed, which are found to be active, or include the antifolate agent pralatrexate, or histone deacylating agents like belenostat, romidepsin and all are found to be active in the relapse settings.
What is the median response rates for these drugs in the time of relapse?
Response rate is around 25 to 30%, sir. With median
We're not
survival,
talking about median time to response.
time to respond.
You do get responses, but responses, how long does a response last? That's what we are looking at. We are only looking at progression-free survival over here, isn't it? At the time of relapse. No, the question is over here. It depends upon the time to relapse, isn't it? Suppose a patient relapses 2 to 3 years after that, your choice of treatment would be different over here as against a patient who relapses soon after a primary treatment. And your choice of treatment will also be different, isn't it? Yeah. So what are the alternate chemotherapy drugs other than the CHOEP regimen that you know of that you can use in peripheral T-cell lymphomas? We know that we don't have access to romidepsin, etc. The larger studies have shown actually futility for its activity in many of these situations, isn't it? Yeah. So what are the other chemotherapy regimens that have shown activity in peripheral T-cell lymphomas?
Dose-adjusted Ampok can be used.
Can be used, but why would you use dose-adjusted Ampok over here? Has intensification of therapy ever helped? And suppose the patient...
Sir, can I just interrupt? We have crossed 8:30. Can you wind off in under 5 minutes, sir?
Yeah. Didn't realize. Yeah.
Nice.
So just for completion, what are the other chemotherapy regimens that one can use in peripheral T-cell lymphomas that you know of? Yeah. Suppose we can't use an anthracycline-based regimen, the patient is saying, and what are the other regimens that have been active?
Combinations also included, Vishnu. Please keep in mind.
So gemcitabine is an active drug in peripheral T-cell lymphomas. So is to a certain extent a platinum-based regimen, as is true for any relapsed lymphomas. And steroids do not have too much of an activity in these patients. And also one must keep in mind sometimes the activity, though it is not the activity of some of the IMiDs like lenalidomide, etc., in peripheral T-cell lymphomas, though with very minimum activity, probably in single digits actually. But we don't have too many options when we treat relapsed peripheral T-cell lymphomas. And also in angioimmunoblastic T-cell lymphoma, there is some data that immunosuppressive therapies like using cyclosporin may help in some patients, but we don't know who are the patients who will actually benefit from something. But I would agree it's not the easiest case T-cell to be discussed because there are no studies, because we hit a wall very soon in our treatment for peripheral T-cell lymphomas. So I think it's just that you need to be a little bit more proactive about your answers coming forth. Don't have to be, you can be wrong in your, but at least when we discuss any case, for example, what the examiner is trying to understand is what is your thought process. It is not whether your diagnosis is right or wrong, or whether your treatment that you give is right or wrong, but it's your thought process, how you are approaching a patient. That is what is important. And Nikhil, if you have something.
Sure, sir. I'll add a little more, maybe specific to the exam. They are all dear MB students. One thing is, any lymphoma case, you need to be strong about your immunohistochemistry. For the matter, when you reach a pathology, even in the other cases, unknown, your CUPs and all that, you need to know your basics about IHC and how you would sequence them. All of us are not in a resource. A lot of the examiners may come from a traditionally resource poor pathology where you have to calculate and see. That is one area where you can improve. And as sir already, should be at least when it comes to management, I can understand you should, once some amount of firmness or a commitment to a form of treatment should be there. The answers are known to you because you are practicing all that back at your own place. Keep in mind, a lot of times your institutional protocol will be the standard of care. Don't hesitate to use that. You should have not hesitated saying, sir, I would use ICE or DAP as a salvage or a GDP or whatever. So, and I do understand that if this had been a B cell, you would have been much more confident. T cell is one area where, little bit because the lack of focus and the smaller incidents we are not there, but you should be able to expect. But lymphoma, you are expected to know it. Discussion can take you elsewhere. It may not be what is your pathology. Otherwise, you have done well, but improve on these areas, Vishnu.
Sure, sir.
And all the best.
Thank you, sir.
Yeah. All the best. Yeah. All the best. Yeah. There's nothing about it just you need to be confident in what you have to express your, as I said, we are just, at least as an examiner, we are only looking at how you are approaching a case and what your thought process. It is never to do with how you are going to treat the patient. No, it is how your thought processes.
Thank you, sir.
Yeah.
I think the best person to teach lymphoma in India is currently you, sir. So I'm very sure the fact that the number of questions I was just eagerly listening. I've been into practice. It is so many things were actually revision new to me. So it is when I also learned so many things from this presentation. So the very fact that we had more than nearly 130 students, people were there, that itself shows that the student community is eagerly waiting for good classes. So thank you, sir. Thank you for accepting our invitation to be the part as an examiner. And we hope that we will be keeping on troubling you with more and more.
No, there's no problem. Thank you. Thank you so much for having me. Yeah. Thank you.
Thanks, Nikhil. Thanks. Nikhil is our in-course examiner. So thank you, Nikhil. So
thank you.
We'll be catching up next month. So, and thank you, Vishnu, for the good presentation and all the postgraduates. So we will be uploading this one in our website. So in case you can, if you want to go back and listen to this case presentation, you can go to the Ampok website. Not only this one, the earlier case series will also be there. So we'll be coming up with a different case next month. Thank you. Thank you. Good night.